Hello, everyone. We're going to go ahead and get started. Welcome and thank you all for joining today's second leadership webinar or seminar of the 2016 program season. We have a great presentation for you today, but before we get started, I have a few housekeeping notes. First, you're all muted upon entry. You'll remain muted throughout the course of the presentation. That's to cut down on excess background noise or feedback. If you have any questions or issues throughout the course of the presentation, you can go ahead and chat those to me using either the chat function or the Q&A function. There will be two question and answer sessions throughout the course of this presentation. One at a little past the midpoint and one at the end. So please submit your questions, any questions that you have that come up throughout the course of the presentation using the Q&A function or the chat function, and we will relay those to the presenter. We will also reference the questions that you submitted via Canvas as part of the assignment. Those are all of the housekeeping notes. If you have any questions, direct them to me, but now I will turn the presentation over to the PCLP Program Manager, Dr. Sybil Anderson. Sybil, take it away.
Thanks, Sam, and hi everyone, welcome back. It's good to be with you again for our second PCLP Leadership Seminar. Today's topic, as you know, is Achieving the Triple Aim Through Health Innovation. So this week, for Unit 2 of our course, you've read Berwick, Nolan, and Whittington's seminal work on the Triple Aim. You've also read a brief on the patient-centered medical home and an article about how one community achieved both through innovation. So today we are extremely fortunate to learn more about these approaches to healthcare reform from a true champion of community health who is at the absolute leading edge of this work, Dr. Elizabeth Cohen, Director of the Center for Health Innovation at Adelphi University in New York, and we're very proud to say a PCLP faculty advisor. Before I formally introduce Dr. Cohen, let me just remind you again of today's format. Today we're going to conduct the seminar in two segments. In the first segment, Dr. Cohen will speak for about 20-25 minutes, after which we'll open the floor for about 15 minutes of discussion. Again, we're going to draw from the excellent questions you submitted earlier this week in Canvas in response to your readings, but we'll also address questions and comments that you post live today using the Q&A and chat functions on your screen. So then Dr. Cohen will present the second half of her presentation, and we'll follow that with a slightly longer Q&A period. So now it is my great pleasure to introduce you to Dr. Elizabeth Cohen. Dr. Cohen is Executive Director of the Center for Health Innovation at Adelphi University and an adjunct professor at the Columbia University School of Nursing in New York. The Center for Health Innovation serves as a regional resource and academic partner to communities seeking to promote a culture of health, community by community in Long Island, also as a model for the nation. The center provides a foundation and infrastructure for creating interdisciplinary, community, and business partnerships and for cultivating innovative leadership with the goal of meeting current and emergent healthcare needs. Dr. Cohen is deeply committed to advancing health equity for underserved, low-income urban communities. She has a strong background in public health, research, community engagement, and community health. As a Robert Wood Johnson Nurse Faculty Scholar in Health and Health Disparities Research, her work focuses broadly on three core principles of whole community: understanding and meeting the actual needs of the whole community, engaging and empowering all parts of the community, and strengthening what works well in communities on a daily basis. It is for this work and work at the intersection of precision medicine and health equity that she was awarded a White House Champion of Change Award in 2015 by President Obama in Washington, D.C. At Columbia, in addition to serving as a member of the faculty in the School of Nursing, Dr. Cohen serves as the Associate Director of the Community Engagement Core of the Irving Institute's Clinical and Translational Science Award at New York Columbia University Medical Center, New York Presbyterian Hospital. Dr. Cohen's decade of work with the communities of Harlem Health Revival was cited by the Surgeon General during the launch of the National Health Prevention Program in Washington, D.C. Dr. Cohen's talk today will focus on how we can start listening to communities as a means to improve health by taking a grassroots approach to community health and wellness. Dr. Cohen, we are excited, pleased, and honored to have you with us today. Welcome, and thank you for joining us.
Thank you, Sybil, so much for that kind introduction, and I could not be more pleased or proud to be with you today. This is my second year with the PCLP program, and I am just so inspired by the work that we all do, that you all do, and that the program itself supports. I'm grateful today for the opportunity to share my work and hope to pick up from where your first workshop left off. And I just want to say that my scholars are on this call, so things are looking good, and are going to start to look even better. And I'm just so proud of the work that's being done across the nation. Bedford-Stuyvesant is the location that I work as a team with, and I love the work there and the care of the patients. So I'm delighted. As we were just saying a minute ago, the talk will pick up from where your first talk left off, and I do really want to make it, as the first slide said, I would like to make it a conversation. So I'm going to talk for, like Sybil said, about 20 minutes, and then we'll take a break here, I hope, hear from you guys, and then come back and finish it off. So just framing the work that I do within the IHI Triple Aim and the articles that you read for this seminar, I wanted to take a slightly deeper dive into the experience of care and population health and how that relates to the Triple Aim and the way that it may reduce per capita cost. But the talk today will mostly focus on population health and the experience of care. So just as an overview, the patient-centered medical home, this is straight from your articles from the Agency for Healthcare Quality, the ARC handout. The strategies put patients at the center of primary care, and they suggest that they're engaging patients at 3 levels: involvement in their own care, the quality of the improvement in primary care practice, and then policy and research development, that this approach will help benefit their health and the population health of the nation overall. And I would agree. But how do we do that? Like, what are the mechanisms that we should be using? How can this be accomplished? So I think that's the first question that we'd have to ask about this type of approach. And while we're asking that, I think we just need to take a minute and say, well, what really is population health? What are we talking about here? So population health is defined as the health outcomes of a group of individuals, including how the health outcomes are distributed. And it can be geographic, it can be communities, employees, ethnic groups, disabled people, prisoners, or any other defined group. But it's looking at the health overall. I'm sorry, should I just keep going? Good? Can you guys hear me?
Great.
Okay, good, that's great, just checking. So it's not just the overall health of the population, which regrettably we're not actually doing all that well with anyway. But it's even if we were, the overall health could be quite high, but there could be differences by group. And ideally, those differences would be eliminated or substantially reduced. And that's what we're going after here. We're going to try to think about the ways that policies, programs, individual, interpersonal, communities, and providers can help reduce that variation. So just a quick look at the numbers, and I'm going to present some data from New York State. And the reason is that we've just finished conducting, and I've just finished writing the Minority Health and Health Disparities Report for New York State. And we did it through a set of listening tours. This is preliminary data. It's been vetted by the Minority Health Council, but it has not yet been presented to the governor, which will be next month. So the data I'm going to present is okay. The results are not for distribution quite yet, but I think it's a really great kind of window into where we're going with health in New York State, and I think the lessons can be used nationally. So poor health is not randomly distributed. It's patterned, systematic, and actionable. And the highest rates of disease are concentrated in communities with the highest proportion of racial and ethnic populations, poverty, unemployment, and low educational attainment. So, and these health disparities manifest themselves in a number of ways: life expectancy, infant mortality, low birth weight, etc., heart disease, cancer, mental illness, homicide, drug and alcohol addiction. So we're looking at kind of these, we're trying to tease out and think about what is it, where can we work, and what shall we do. And I'm going to just show 2 or 3 slides about where this took place and how we're thinking about it here in New York. So this slide is just meant to say that that non-white populations will not be the majority probably going forward. That 44% of the state is non-white right now, so that we just feel like this idea that there's going to be a majority population and minority populations is fading fast. The state is very mixed, and there's a movement towards a more diverse population overall. We wish that this were not the case in New York State, but the state is segregated and into communities, some of which experience very poor health. And so what we did was look at the communities where there's 40% of the population or more living in poverty. And so we looked at both their health outcomes and the poverty and matched those together. And then we actually conducted a listening tour across the state and went and spoke with people about what we can do, how they can become more empowered to become more involved in their own health, and how we can begin to reduce the disparities. This slide just gives information about the poverty levels. The literature makes a strong association between poor health and poverty, and we believe it to be one of the root causes of poor health. But in this particular slide, it just demonstrates that Blacks and Hispanics, on an average, continue to experience higher rates of poverty. So we're hoping that this data will change shortly. This is the percentage of adults without health insurance, and it's just a demonstration that there's Hispanics actually currently in New York State, although again, we're hoping to see this be reduced with our next data collection set. Hispanics are currently underinsured or lack insurance, Hispanics and Latinos. So, so we're trying to tease out some of these. Now let's see. Oh, there we go. So what do we know? We know that health outcomes are shaped by a wider set of forces, and that health inequities are a product of a complex array of intervening variables: individual, neighborhood, policy, institutional, etc. We believe that the circumstances in which we're born, grow up, live, and work determine our health. And we also, those of us that have been practicing, feel that what we have been doing has not worked, that the traditional solving problem methods that we've employed over the last 35 years have not significantly transformed neighborhoods, and we have not reduced a widening disparity. So we're trying now to think about a new approach, and possibly one that articulates, I think, very closely with the way that the AAAM and patient-centered medical homes have been designed or will be designed. So I think many of you are familiar with this slide. It illustrates, it's the socio-ecologic model illustrating and demonstrating the individual, interpersonal, social, community, living and working conditions, and then our society at large, and the various places that health is impacted at all of those levels. So the determinants would suggest that there's work that we can do at the individual, the interpersonal and societal and community levels that will change health. So this then was our first attempt to really see what would happen if we helped ourselves as providers. So I'm a nurse practitioner and a nurse practitioner by training, and then a researcher by advanced degree in public health. So what would happen now if we helped ourselves as practitioners and the community in general look at some of these root causes of the health disparities? So we discussed the social and economic environment, the physical environment, and the person's individual characteristics and behaviors, but that really is just the surface. What we want to do is think about what we can do that rests below the surface, what we can do to produce good health at the beginning, this idea that the plant will be only as healthy as the fertile soil that it is buried in and that it begins in. So how can we set the stage so that the soil is fertile to start with, and see if we can produce better results, stronger results, and lasting results with this idea that we can have this really a great start. So in this slide, Yvonne Graham from the New York State Minority Health and Health Disparities and I, and a group of people who have been working with this, have been kind of redefining the traditional public health approach versus what we have been, and I apologize, I don't know if on your screen the slide is as small as it is on mine, but I'll walk you through both. So the traditional public health approach, which has made quite a number of excellent improvements, is based on a biomedical disease paradigm. And this is an approach that we've been using for a long time, and we have been able to make some change, but now we are really seeking to close these disparity gaps. So on the left-hand side of the slide, it says traditional public health approaches, and it starts with, for example, defining the problem, identifying the risk factors through research, testing interventions, implementing the interventions based on scientific and systematic review, evaluating the interventions based on a research paradigm, and that keeps on going around, and that's how we develop new interventions. What we're proposing is that if we really want to further reduce or eliminate the health disparities, we want a more connected, coordinated, and community-driven approach. So the one on the right, the community-driven approach, incorporates the community at every level. So, for example, it says that the surveillance, first we define the problem with surveillance and community identification of the problem. That then after the community identifies the problem, the research community basically works within that identification and gets on board with what the community feels are their priorities. Of course, it helps that there's buy-in because we're working on the things that people feel are most important to them. We test the interventions, integrating the community participatory research approach, implement the solutions, and test them scientifically still. We want the model to be robust and scientific and stand up to scrutiny. We want to do things that will help. I think in general, people in this field feel like there isn't any time to waste. So we want to do things that will matter and that will make a difference. We want to test them rigorously so that we know that we have good data. We want to be able to share them broadly if they do work so that people's health can be improved. And then lastly, evaluating the interventions for sustainability and community ownership. And of course, that would really help. It has to matter in the thought and the voice and the view of the community. The change has to matter to have improved health. And it should have a way that we can sustain it. So that's the approach that we use here, and that's the approach we will be using going forward. So in today's talk, I'm going to actually present, as I said, preliminary non-vetted, non-approved for release, but good for this purpose, results of our Minority Health Council community listening sessions in the areas that we just identified to engage community residents in the problem-solving efforts towards healthier communities, to create a safe space for community residents to organize and identify priority issues through their own lenses, and then to learn that we should learn what the problems are through the eyes of the communities, to have a better understanding of how to develop policies, allocate resources, and support an infrastructure that works best. And we tied this to funding from the New York State Minority Health Council. So people will have funding based on this methodology and based on our results that will be given to the communities for their own, to improve health as they see it, and as they, with the help of researchers and academics and the local resources and government. So we're hoping for a bit of a turnaround here, or at least the beginning of a model that we can use. So the communities were primarily located in low income, as we said, 40% or greater living in poverty in defined geographic communities in Buffalo, Rochester, and Albany. And I'll just show a few, it's 1 or 2 slides from each of the, from the sessions, just so you can get a feel for what we did. So these all took place earlier this year. And they were a listening session by the people, for the people. They were given kind of local flavors through their names. So they were either called Voice Your Vision or Turn It Up Buffalo was this one. To give Buffalo residents a platform to share their views on health and access to care without judgment or fear of retaliation, to provide the healthcare professionals and political officials with the opportunity to really listen. So the sessions were facilitated by community members, and if there were dignitaries there, they were participants, not the leaders. They needed to be there to listen. So I think based on your first workshop, I thought this was really, really interesting, given that some of the suggestions in the first workshop of this series asked about, well, how can we understand more of what people want, and in what way should physician offices change? And so this is what we saw, that neighborhoods should be used as a platform for promoting wellness and the delivery of healthcare services, that the culture of physicians and their offices must change. And we can talk about that, your feelings about it, and also what specifically they were thinking there. Approaches to health education and the promotion of wellness must be changed, and new strategies should be formulated to deal with the unique health challenges of different social groups in the community. So as I said, I just did 1 or 2 slides on each one. This is the Rochester, it was called What's Going On. All of them were held at neutral places, so these are not held in the auditorium of hospitals, or these are all held in central locations that were either community, it was community setting, so either like a community resource center of some kind, or a school, in this case a school. One of them was held in kind of a basement of a barracks, but we purposefully chose things that would be centrally located, easy to get to. Childcare was available at every one of them. Food was available at every one of them. Entertainment to just get people feeling more relaxed. It felt real. It was good to have participants with mental health. We made them all, they had to be, the place they were held had to be completely accessible for people in wheelchairs. We really tried to get the community out in a number of different ways, through radio, through barbershops. One of them actually had a men's barbershop come in and do a barbershop session. In the beginning, you could get a shave, you could get a haircut, and then you could talk about your health. So it was really interesting in that, both the feel of it and the information that we got. There was much positive energy and feedback generated. Participants were intrigued, encouraged, and engaged. We collected raw data in their own voices. Stakeholder relationships were strengthened and partnerships formed. And all of this data has been returned. The initial area reports were returned to the communities before they were compiled into the large report, and the large report was returned to the communities before it was vetted by the council. So we wanted to make sure that not only did we capture their words, but we also captured the spirit of what they were saying, and that they got a chance to see it and edit it before it went out from the communities. But they really did feel like they were able to contribute. Oh, this was the one that was at the Armory, was the Capital Region. These were some ground rules that the Capital Region made up for themselves. No racism, no sexism, no homophobia, transphobia, fatphobia, ableism, ageism, hate. They really wanted it to be a place of acceptance and love and active listening so that we could understand what the health concerns were and begin to address them. So I'm going to just, I have only 2 more slides for this section, and I just want to tell the scholars and people on the call how we actually did this. So the first thing was that there, as you can see from the Armory picture, there were tables that you could attend, and the tables were women's health, taking charge of your health, violence and trauma, spirituality and health, seeking services in the community, youth and adolescent, aging and elder care, people with disabilities, LGBTQ health, men's health, and an open topics table. So first we collected all the listening session data by table, and then we analyzed it by table, so then we had the priority for women's health, men's health, LGBTQ health, etc. And then we shuffled all the data again and reanalyzed it by overarching theme. Cultural competence, access to care, things like that. So we have 2 sets of data that I'll present after this section, after we take questions about just this section in general. And I think you'll find it very interesting and very enlightening. We really enjoyed doing this and listening. I've been in the community for a decade, but it was interesting to watch other people listen to the community and try to take in and understand what we were hearing, and then how we could analyze it and continue this partnership. I won't do it now, but we can make available to you a 15-minute link. This links to a video about all 3 Voice Your Vision sessions, and you can hear a little bit about them, and you can hear some of the participants speaking about their health needs and our findings. So with that, we can watch the first like 3 or 4 minutes at the end, depending on the length of the seminar and how many questions we want to get to. So these again were the table topics, and with that, I think we have our first break in the lecture or in this workshop, and I was going to ask you guys, what do you think the main issues might be in these groups? I used this cartoon. The good news is we're getting a lot of feedback, but the bad news is we're getting a lot of feedback. We were getting a lot of feedback. So what do you think we might have heard?
Fantastic. Dr. Cohen, thank you for this great opening segment. And so scholars, unfortunately, we won't be opening the lines for you to voice your answers, but we definitely encourage and invite you to post your responses using the chat and Q&A functions, and Sam and I will read them, and we can engage in discussion that way about them. So I think this is a really great question. We have been talking, as Dr. Cohen mentioned last week, we were really thinking a lot about what it means to listen to the community and to innovate within the community in partnership with the community. And so in these 3 cities, what do you think were some of the issues that the community members voiced as concerns? So take your time thinking through that. In the meantime, I would like to pose a question, Dr. Cohen, that came earlier in the week from a scholar. And so it has a bit of an introduction, but here we go. The article by Barbara Brandt titled Aligning Practice Redesign and Interprofessional Education to Advance Triple Aim Outcomes suggests increasing the duration of training to allow for interprofessional rotations that would allow mastery in other areas that would improve quality of care. Do you think that it would be more feasible to recommend changing requirements to inter-medical school, and I would add graduate health programs? Do you think it would be more feasible to recommend changing requirements to enter those programs that would include a public health course that could introduce social determinants of health and incorporate additional courses within the medical school curriculum that could cover these same interdisciplinaries related to the triple aim?
Yeah, it's such a great question, and I do appreciate it. And I think a lot of, the health policy in general, will always be your biggest lever in terms of health. So let's think a little bit about health policy programs that have helped the public health overall, things like smoking cessation when we outlawed. So when I started, you can't see me, you can only see the picture we posted, but when I started as a nurse, we actually smoked at the nurse's station in the hospital. We smoked right in the hospital. It was completely crazy. But in the emergency department, you could smoke at the nurse's station. You could also smoke in the lounge, but most of us didn't. Most of us who smoked right at the nurse's station. It's unheard of now. But just to say that when we put the smoking restrictions on, we really improved health, including my own. So I think policy, always policy is your biggest lever. So the question is, how do we relate policy to health? What can we do so that all the tools that are available to make people healthier, we've incorporated into the curriculum, as you just said. So I put forward for you then two things. One of them is that George Washington University was just on National Public Radio. What an exciting program they did. I think there may be scholars on from GW. I don't have any affiliation with GW, by the way. I just think they did such a cool thing. So now with every so people don't go to medical school or nursing school to learn policy in general, and sometimes those discussions start out as health costs take up such and so % of the gross national product, and many of you scholars and maybe even other health professionals kind of shut off at that point. So what they did was with every disease, so childhood asthma is probably the best one to talk about right now. With every disease, they taught they taught normal anatomy and physiology, then they taught pathophysiology, then they taught the disease, then they taught the medications, just like we're always used to, the medications, the treatment, the diagnosis, well, diagnosis, medications, treatment, and then they went on and added to every single one of those a policy component. So when they teach about childhood asthma, they teach about the risk factors and the diagnosis and the treatment and the management, and then they say, and the policy implications are the dust and roach and rat infested housing, living near a garbage or bus depot, and run down them. And then they talk about what you can do as a health provider vis-a-vis that policy. What should you be doing? How should you can ask people about that. You can refer them to programs that monitor housing conditions and all that. So I think with some very simple, very low cost interventions, there's no cost there. They changed it. It's actually the medical school that did it, but they changed their curriculum so that each disease just had this one added component. And what an exciting thing to do that's going to change the lives of millions. Just a great, thoughtful policy intervention that runs straight through everything. So now we have it all. So I would make changes like that to curriculum, which I think were quite brilliant. Should we change the requirements for letting people into medical school and nursing schools? Maybe. I mean, I think public health is going to be the way that we're going to impact the most amount of health. But another possibility is that the Center for Disease Control and Prevention's Office of Minority Health and Health Equity issued a set of grants, and we have one for workforce at Columbia, where any professional, dentists, nurses, plus minus physicians sometimes, because they can be considered in the pipeline already, but people from a number of different areas, including, for example, advertising, sports medicine, some of these other tangential, what we might consider tangential areas, can get additional training in public health, because we don't just need health professionals, we need to sell it to people in innovative ways. So artists, urban planners, architects, all those people maybe also need public health training. So I don't know if we just need to look at the nurses and doctors. I'd actually like to see urban planners and other types of people think about how they can contribute to public health.
Excellent. That was a great question and a fantastic answer. So thank you so much, Dr. Cohen. I believe Sam has a second question. Yes, Sam?
I do. This is another question that was submitted by one of the scholars based on the readings done. So they would like to know, what suggestions do you have on how to maximize the quality of care we give our patients within the incredibly short time allotted for physicians to spend with their patients?
Oh, yeah, so I really like that question too, and maybe some of the results of what I'm going to talk about in the second half of this presentation will actually inform that answer. I think there's a couple of things that that we can do. You know, one of them is the people who we spoke with in these communities are asking for how they can prepare for these types of visits, what they can do so that the patient too wants to maximize their experience of the visit. So so coming with a list, knowing your medications, using that time as wisely as you can, so that it's taken, you get your most important health needs addressed up front. I think people who are in the field for a long time have this, there's like this nightmare of you put your hand on the doorknob to leave the exam room and they say like, oh doctor, one more thing. And that one more thing is always the main thing, but we haven't covered it in the visit. So helping people prioritize their needs and wants, having systems in place for things like medication renewal, and some of the stuff that may take time that you don't need to use during the appointment are all good things. And people were actually asking for that in this study. They said, how can we maximize our time? So I think everyone would like to do that. The other thing that surprised me about that question, so surprised. So again, my training is as a nurse and a nurse practitioner, but in the first workshop, the physician who presented from Altamed was saying, we don't have to do everything ourselves. Physicians don't have to. Certainly not. We don't, the nurses and nurse practitioners and physician's assistants and other physicians, but we have thought of ourselves on your team from all of this time. I never realized, I hope the physicians that I worked with weren't feeling that way. I was surprised to hear it. So that was a tension I hadn't felt. We're all here to serve the patient. So I would feel remiss if I didn't contribute as much as I could at the nurse practitioner level, which is quite a great deal in New York. We have independent practice here. So as much as I can deliver to the patient, I would want to. I wouldn't want to do any less. So I think you can also help that this team-based approach, which I know they're working on in Bedford-Stuyvesant, the team-based approach can really help because everyone is there to serve the patient, and I want to be on that team too. So, so allowing people to work to their highest levels and preparing the patients for their appointments are two things I could think of off the bat.
Thanks so much. You know, I actually have a follow-up. I see that some scholars have begun to respond to your question, but I have a follow-up from a scholar, an earlier question they submitted this week that connects with what you were just talking about, Dr. Cohen, and that is, you know, given that we have these triple aim goals, right, and the focus now is on getting teams focused on these shared goals. The question is, in what ways is it challenging to actually get everyone on the same page due to the the different goals, or let's say different objectives they have and different perspectives on the basis of their different training. In what ways is that challenging, and how can those challenges be mitigated?
Well, I think the scholars who I'm working with are going to try to answer that question over this summer. I mean, it's a great question. I know they're on the call, so your question is a good one, and I think we are trying to think more creatively about that. We are all here to serve the patient, every one of us, right? So I just see us all contributing in all of the possible ways. But I think the project that we're working on this summer will try to help identify some of the facilitators and barriers of team-based care. So if you check back with us in about a month, we'll be happy to let you know the results of our survey. And I think it's probably out there in some of the literature. I mean, I could venture an uneducated guess, but I don't know that would help us right now. I'd be interested if the scholars can type in what they think. Some of it is I don't know. Let's find out if people have a feeling about that. The one of the questions that was submitted also, if it wasn't submitted for this seminar, it was for something in a related way. There are specialties that use team-based care already. Management of chronic diseases like heart failure, diabetes, things like that are very much a team-based care approach because the diseases are chronic and difficult to manage and require a lot of attention in the beginning. I'm in a practice, my clinical practice, which was cardiomyopathy and heart failure. I don't do it now because I'm doing research, but that clinical practice is rich with nurse practitioners and doctors, all of whom honestly are in kind of a love fest in trying to get these patients, take the best possible care of these patients and get them on solid footing or towards transplant, whatever phase they're at. So it can be done. I think it's a retooling of just making sure that everyone is centered on the patient, the best care of the patient, and in some there are models for it. But like I said, diabetes and heart failure being among them, where I think we can learn a lot from successful practices.
Great, thanks so much. So Sam, you said that there are some responses to Dr. Cohen's questions. What might be the main issues in the groups in Buffalo, Rochester, and Albany?
Yeah. A scholar posited that one issue might be privacy. Groups might want to speak in an all girls or all guys group, depending on the topic that is being discussed, or time. Some of the sessions might interfere with working, picking up kids from after-school activities, etc.
Oh, thank you for, first, let me just clarify. These listening sessions that we conducted were only they were one Saturday. So people just came, and daycare was available at the sessions. And we did have a women's health and a men's health table, which were primarily attended by people who identified as women, people who identified as men. But this particular listening session, this was a one-time, this particular thing wasn't ongoing to address a specific health issue. It was just to get their feedback. So people, I'm sure that there were people that couldn't come, and one of our limitations of the study is that we noticed that some groups were missing or weren't as well attended as we hoped that they would be, and we'll do better the next time we hold a listening session to be sure that those people are more actively engaged, or that we work harder to get our information out for them.
Excellent. So I don't see any more scholar responses to this question, and I'm really curious to hear about what some of those issues are. I take it, Dr. Cohen, that that's coming up?
Yeah. Yeah, so it is coming up, and I'm not going to take you through every one of them because we would be on the phone for a very long time, so I'm just going to give you an example, like one or two examples of the type of feedback that we got in each of the sessions. And then if people would like, of course, the report will be available broadly and widely in about a month. and you can read about it, and you can also see for, I think maybe specific to the triple aim, each one of these recommendations that I'm going to talk about right now was paired with action items, individual, interpersonal, and policy action items that we can take right away, because the report was meant to drive funding for New York State, so we wanted to be sure that people understood what we thought were the next types of things that we would want to be looking for. So it was a listening session, so we used this Wordle type of thing that's very popular now. And I think people who are familiar with it know that the larger and bolder the letters, the more people talked about that word, the more that word came up. So this, for experience of care, which is part of the triple aim, when we asked about taking charge of your own health, you can see here that people use the word health and people, health information, choices, community, but they also use things like stress and racism and differences and things that express some frustration. So I'm just going to give you an idea about more specifically what they said. More specifically, participants expressed empowerment, freedom, and advocacy can be achieved through better health. They wanted to learn about exercise, healthier diets, how to reduce stress, eliminating the fear of having or being diagnosed with the disease, knowing one's own health status, and becoming an expert in one's own health. I think this is typical of many communities. Some people were hesitant to even go to the doctor because they don't want to know if they have something. It's not that people feel like going to the doctor will bring it on, but of course that is how people learn that they have diseases, if they go to the doctor. They didn't have heart failure when they went in, but then they received a diagnosis of heart failure when they were there, and so it can be very scary, especially if you feel like something's wrong. I would be lying to this group if I said that I myself never did that if I thought something was wrong. I mean, I think some people run to the doctor, but other people feel like I'm just going to try to push through it. And we heard a lot of people trying to just push through things that were concerning to them. The recommendations for taking charge of your own health included things like including health education in schools at all grade levels, especially around reproductive health and sexual education, using that socio-ecologic model, individual, interpersonal, community, and societal levels, addressing issues of stigma, childhood experience, sexual abuse, and other types of trauma that may impact on physical or mental health, and providing care in a culturally competent manner, which people, I think there's a tension between people not wanting to ask too much in these communities about stress and everyday violence, and we had a section that was just on violence and in the community, and I think providers, especially in a 15-minute visit, don't want to ask, but people want to be asked about their mental health. They want somebody to say, how are things going? They want the opportunity to talk about it. So I think we heard that stigmatized issues are not addressed and then are unspoken, and then then people don't get the help that they need. I thought the men's health tables were fascinating. Again, none of this was anything that I don't think really surprised me or anyone else working on the project, and none of it is necessarily rocket science, but we were grateful to learn from the community, and we also were sorry that some of this still exists. We kind of knew it was there, but when people put words to it, it made it all the more real. Men in general don't seek care. Men of color specifically don't seek care. And so what can we do? How can we help that? And you can see some of their words here. One man, it was so interesting. He's like, I have a question, he says. I have a question for you guys. He says, women have women's doctors, and for men, we OBGYNs basically. Now, for the men on the call, just so you're aware, sometimes women see their OBGYN to birth their children, obviously, but then sometimes they stay with the OBGYN as their general practitioner. They just kind of get all their medical care wrapped up in that woman for as long as they are childbearing, and then eventually they start seeing an internist again. But sometimes while they're in the childbearing years, they just kind of get everything wrapped up into one. And this man knew that, and he said, you know, women have women's doctors, and they're specifically women's doctors, and they're specifically focused on women's issues, and they treat women, you know, they want to treat women, and they treat them respectfully. I think we ought to have men's doctors, and I think the men's doctors ought to know how to treat men, how to talk to us, and what we want, and we are, you know, have that same type of relationship. And it was such an interesting thought, and kind of a paradigm shift. So they were looking for more culturally competent care that understood the health aspects of being the tension of being a man of color and needing to be strong and needing to be healthy and working and the number of different things that can affect men's health, and the way that tests like colonoscopies and prostate exams are performed, and how we can make preventative health services kind of cool again. What we can do to demonstrate how that preventative health services and health services in general are a way of being in control and being in charge. And they also wanted it available in barbershops and at sports and car events. They wanted the faith leaders involved in men's health issues, specifically men's mental health issues. We have a model program for that at Columbia, by the way. And interventions to encourage men to use preventative health care services, taking into consideration the role that they play as protectors and providers. So I think that's the kind of, when we say culturally competent care, we're at a different level of culturally competent care now. It's not, it may be race ethnicity, but more it's understanding the roles within that relationship and the truly different approaches that might need to be taken with, you know, with men, with having an office that welcomes an LGBT community. Last summer, my scholars did a project where we just did a survey of offices to see if you were to walk into this office, this medical facility, this federally qualified health clinic, would this be a welcoming environment if you were an LGBTQ trans person? Would you feel welcome there? Is there posters that reflect your orientation? Is there staff that, you know, that seems to understand? Do the forms force you into binary choices that you don't feel reflect who you are? So what can we do in those areas to make things more culturally competent? I'm not necessarily talking about the cultures as we might think of them in general. Again, similarly, we talked about the role of faith, and that's the essence of all of my work for the last decade. So I think maybe I'll hold on that one for now, but I think the churches can and should and do play a tremendous role in people's health, and we can find ways that we can equip the churches and church health ministries and clergy to guide people towards not just spiritual and emotional health, but physical and community health as well. And people who are interested in that can, you know, can see me after this for as much as you would ever want to hear on that particular topic. And a show with my community partner who's from Abyssinian Baptist Church, and we have a show that, you know, that comes here. So see me about that if you're interested. Lastly, for this part, we produced 10 to 12 actionable items that would begin to address health disparities. And I'll just show you the ones from youth and adolescent, just to take a break from the other ones. And again, this is just a sample. There's as many of these as there are top table topics. So youth and adolescent health, this is what the youth and adolescent health tables came up with when we said, what are the health issues that affect the youth and adolescent health in your community? They really said, we need to feel safe emotionally and physically. It's not so much about health for us. It's about living to see another day. We're not worried about checkups because our safety is more at risk and more immediate. And Sorry, there we go. So what we wanted to think about was sorry, I'm just going to go back for a second. I don't mean to drive you crazy on your screens. By just pulling this, I wanted to just highlight the fact that, and we heard this in the violence and trauma tables as well, that it's hard to talk about health in the health of somebody, and even something like smoking cessation, if you're not sure if you're going to have that much time. It's hard to invest in your long-term health. So I wanted to bear this in mind as we go forward. And we do have a set of recommendations on trauma and violence, community policing, making neighborhoods safe. Similarly, it's hard to encourage walking exercise if you don't feel safe walking, if the sidewalks aren't a safe place, etc. So I just wanted to highlight that this takes place within the context of the fact that we need to think about keeping people safe in their communities and in their homes. For action items that we wanted to, that we could do that would address some of the health issues given the context that they take place in. They suggested increased educational programs that address skills such as, and this comes from your questions, the scholars' questions earlier, how do I make an appointment with a health provider, and how should I engage in a dialogue during the exam? What would you like the youth and adolescents to do so that they can make the best use of their time? Health in the schools, in adolescent, middle, and high schools, we thought would be a great and worthy intervention and low-cost, high-impact way to reach the kids who we may not have been able to reach otherwise. Co-locate family clinics in elementary schools. Maybe we can get the parents to come in as well. Family planning materials are needed and need to be more widely available. In the youth and adolescent section, excuse me, we heard from people who had children while they were still in high school, and that has been seen as in affecting people's health, as you imagine that it would. So more information about what to do if you're a new parent, how you can take care of your health and the health of your child, and allow them to complete their high school education. Let's see. Again, this is just some of those practical suggestions. Pre-printed list of questions for doctor's appointments. Recognize the use of technology, so texting information and getting information from people in a way that still protects their privacy, but just to recognize that electronic communications are key in that population. And we also felt strongly that things like just say no in all of its forms, in drugs, in sex, and that's not as much of an empowerment as saying yes to something that is connecting somebody, that has an avenue for success, where you can get kids involved in mentorship programs that reinforce value and self-worth, that alternatives have to be offered. Gang alternatives, gun alternatives, there needs to be basically and essentially there needs to be a path out, and it's up to us as healthcare professionals to demonstrate some of those paths out. So the overarching themes then, provide culturally competent team-based care. So right back to the triple aim as we know it, and as we have been discussing. We identified that we should be meeting people where they are. We need to pay attention to the changing family structure, and that also traced back to both teenagers who were parents, but also middle-aged people who are grandparents, and there's a changing family structure overall. The family structure as we've kind of defined it is not actually the case in most of the cases. So what do we do with these new blended families that are constructed differently, and how can we care for them the best that we could? So if you have a grandmother, if you have a whole group of grandparents taking care of children, what does that look like in terms of how do we structure that for the best outcomes for both? Addressing issues of transportation, cost of care in the built environment, stigma for mental health among other medical conditions. We need to help people talk about it. We need to give them the language that they can use to talk about it. We need to empower them to talk about it. We need to ask in a non-judgmental way, and then we need to have a plan to help them, to refer them or to help them ourselves. Providing opportunities for ending poverty and addressing the social determinants. Reinventing healthcare to encompass prevention, health, and wellness. That's another place that some of your questions regarding the triple aim, I think, could really play into here. How do we leverage this? One way to reduce cost is for every diabetic that you prevent, that's going to reduce cost immeasurably. So how do we do that? How do we focus on prevention? What, kind of, where's our National Institute of Health prevention, so that we don't just stay in the medical model and treat diseases after they happen, but get ahead of them? And then incorporating and educating the state, educating people on the state of genetics and emerging issues in health. People felt like they needed current information and new information as it's coming, so they don't get left behind and left out. I'm going to stop there. The rest of the slides are on my center, and I can talk about it very, very briefly, but just to say we do some of the things that I've been talking about. We're involved in Native American health in a program called the Unka Chung's Nations Initiative to End Diabetes, and it comes from a Native American reservation and tribe on Long Island. They've invented their own diabetes prevention and chronic disease management program that we're now trying to help them institute, or they're trying to help me help them. We think about an art meets science approach. This was a program that paired performing arts, namely in Angels in America production, but then we recently did it again on gun violence with a talk back and a night of action. So just trying to think of these other the intersections between health and culture, health and wellness, health and public dialogue. We did one on birth outcomes. Similarly, Department of Health, perinatal services, school districts, pediatricians, perinatal doctors, early intervention specialists, etc. So I think I'll conclude with kind of where do we go from here, and then we'll take the next series of questions. So on the topic of where do we go from here, we've built this system that I think you can contribute to with the triple aim at the base, at the primary care clinics as a base of support, which then on top of we can build communication and collaboration, mutually reinforcing activities that help us both, common progress measurements and targets, and then having everyone work towards a common agenda. So that's what we learned in our listening sessions, but I think it's also what you're learning in this program, and what we're trying to all move ourselves towards. So with that, I'm going to conclude the formal part of the lecture and take the rest of your questions. The cartoon just says kind of a la carte. It's the least amount. Sympathy clucks is $10 per cluck. Personal tidbits, 25. Concrete suggestions, 75. And sitting and listening, $150 an hour, but we felt like it was worth every minute. We really wanted to try to work ourselves up to the sitting and listening part, and I think we did. So with that, I'll stop and take questions.
All right, thanks so much, Dr. Cohen. I think Sam will pitch the first question this time around. And I just want to remind scholars, don't be shy. You've got great questions in your mind, I know, because the evidence is that you sent us some already, so I'm sure you've got some late-breaking ones too. Go ahead and use the chat functions to send those along, and even just comments. They don't have to be questions. We look forward to hearing from you. So Sam, take it away.
Great, thank you, Sybil. So a question that was submitted by a scholar in advance of the presentation was, if pursuing the triple aim involves specifying a population of concern, how do leaders balance and address all of the various needs present within a population when trying to improve health outcomes?
Well, that's really interesting. And how do we choose a population even to start with? This data and this presentation would suggest that we ask them, what are your main concerns? What is it? What does it feel like? What does it seem like to you? We're starting to see, and some of us that have been at this for a long time have had this secret for a while, but it's more widespread now. A colleague of mine at Columbia, it's a great little story, wanted to do a study on how people learn best. In what way would they like some results of genetic testing returned to them, and how do they learn? What's the best way for them to receive these results and learn about them? And so she designed a very rigorous study that included testing people's learning styles through a standardized tool, and then sending the results to them. And in the end of the day, after having designed this whole very complicated, controlled, randomized style about how people learn best, I said to her, wouldn't it be better if we just said, how would you like to receive your results? Would you like us to call you? Would you like us to send them? And then we could follow it up, because we want to study this. I don't want to do it just as a service thing, but we could say, how satisfied were you with receiving your results that way? If you could choose again, would you still choose that, or would you choose something else? Because at the end of the day, randomizing people or conducting these long surveys isn't going to be the way for us to practically deliver information to people in the world. So we can just ask them, what are your priorities, and how can we help you realize those? And I think it has rigor to it, but it also is is practical and kind of a shortcut.
Great, thank you so much, Dr. Cohen. So I want to pitch a question from a scholar also submitted earlier this week that sort of connects with this. So we've been talking about the importance of listening, really listening to patients. The scholar question is, what happens when patients become an impediment to the better health outcomes that a team-based care approach seeks to achieve, for example, through lack of compliance? And part of what so there are two things. One is, in these listening sessions, of course, you're hearing from people who show up, who are leaning in and really contributing. So they have also given good information. The statement from the young adolescent group, really powerful. Like, how do you expect me to really focus on being healthy when I'm trying to focus on staying alive? When I'm just focusing on being safe. So I hear you saying that, listening to the community and meeting them where they are is an important part of that, but still there seems to be a little bit of a gap. Like, how do you reach the folks who really are way out there, who aren't showing up to voice their concerns and perspectives on this?
So I'm a practitioner for so many years, like 33 years now, and I'm going to speak to this, kind of as a medical professional, but also just having seen the time. I have the experience and the wisdom of just straight up time on this one. So I want to make a plea. You guys are students now, or about to be practitioners. We have to think more carefully about this lack of compliance issue. People, if you're giving people, advice, and I'll go back to the heart failure example. I used to tell my husband, I'm I don't know, 60% a nurse practitioner and 40% sales. I'm trying to sell people on these drugs, and the drugs for heart failure, for people who are not familiar with them, make you feel worse. You don't feel bad. In the beginning, you don't actually feel bad from your heart failure. You feel a little winded. the drugs make you feel worse. They're fatiguing, you get impotence. They're not, some men develop breasts on some of them, so the drugs are not that much fun to take, but they will save your life. But you feel crappy on them in the beginning, and then we taper them up to make things worse. So, but eventually you level out and you don't feel bad anymore. The thing about compliance is that if people are agreeing to do something in the office and then they're not doing it, we didn't really do our job. They just finally wanted to like get away from us. We didn't really find out if it could be done, how it could be done, if they had the tools to do it. Just telling people to do something and then being mad about their lack of compliance it's a surface complaint. It doesn't really take into account the fact that we didn't do a good job in finding out what the barriers were. So this idea of motivational interviewing, of asking people how much of this do you think you could do, or how do you see yourself doing this? So if you're giving a diuretic to a cab driver and then you're mad that they didn't take it, well, because you really didn't think of, you meaning me, Dr. Cohen, I didn't think about the fact that I can't give a diuretic to somebody who works outside or works in a cab, or that's not a good plan for that patient. So that's on me. And the first time maybe, I mean, you've got to ask them. You've got to ask them what it is that is, how they see themselves in an honest discussion. How do you see yourself enacting this plan, and what can I do to make sure that you enact the plan? Because the best plan in the world not enacted isn't the best plan in the world. So let's be honest about the fact that it's a two-way relationship, and that it's my job to design it so that the patient can do it. And if I didn't do that, then that's on me, and I've got to figure it out. Similarly, I mean, we just have to think. I think we have to think about it more. I think it's too easy for us to say they just didn't do what I told them. I mean, one of the reasons that I became involved in this type of work is that I've noticed that the system that we currently have of people coming to my office and me telling them what to do and them doing it, that's not actually working. So we have to retool our side on how to do that. The second part of the question was given good information. What can you remind me about what that was? Is that we gave them good information?
Well, actually, the other part of it that I'm interested in is, you in the listening sessions have been talking with patients who actually come forward and show up. But a lot of the issue, some of the issue, I guess, of improving, say, the overall health outcomes of the community involves people who just don't even show up. So, how do we reach those folks?
Yeah, and I would say the same, that we've got to go where people are. It's just an outdated model. It's just, look, my son was sick, and there's a Medi-Clinic, like a Doc in the Box, 3 blocks from my house, where I live. And we just went there. I mean, we've got to either go where people are, or we've got to have sites. I get my flu shots at CVS because that's where it is. I mean, it's close to my house. I'm there already. I think doing this kind of just-in-time delivery will help people. People are really, really busy. Many people, if they're lucky, are working 3 jobs, right? So, and if they're not, then transportation can become a real issue. One of the interesting things about working in Suffolk County, where the Indian reservations that I work at are located, is that they have rural transportation problems. They have no subway, scant bus service. If you don't have a car, there's just no way for you to get anywhere. These are people that are staying put on the reservation because there's no way to get off, and there's no place to go if they could. But the situation there, public transportation wise, is miserable. So I think we've got to help people. We've got to either go where you are, like your school, your job site, your project. If we could open a clinic there, that would really help, I think, get people to the medical care that they need. But this idea that they're going to come to us at 2 and then we're not running, we're running late and can't see them till 3. I think people are frustrated with that now.
Thanks so much. Great answer. And a large part of what I'm hearing there, I mean, earlier you talked about reaching into neighborhoods, like utilizing the neighborhood, thinking about health from a neighborhood perspective. I think in contrast to the way we often think of it as like, oh, I'm going over to the doctor's office, or oh, I'm going to go over to the community health center because that's where we talk about health. But but expanding it, bringing it to the schools. Last week, a scholar suggested, hey, why don't community health centers address the food desert problem by creating grocery stores, opening grocery stores, right? So that the health center can be in the grocery store. I think this is just really fascinating, phenomenal. So Sam is going to share with you one response to your last answer, and then pitch another question.
Okay, I'm going to ask if you can just put your phone, if you're typing and can put your phone on mute, that would help me tremendously.
Oh, that's not you typing, that's somebody else typing.
Yeah, that's not me.
And it's not me.
Okay.
So,
yeah, I think it's background from the office here, but
okay.
about muting one.
Sorry about that.
So the comment that we received was from a scholar who wanted to thank you for addressing the need for sales and motivational interviewing in the exam room. This is an area I've tried to emphasize with other providers, and I'm glad to hear you echo these sentiments. And then the question that came in from a scholar in advance of the presentation was the last article aligning practice redesign and interprofessional education to advance triple aim outcomes denotes the ideal integrator manifesting itself from a collaborative relationship between a local university and federally qualified health center to align professional education with clinical practice redesign. What barriers do you feel must be overcome to see this occur systemically and consistently nationwide?
It's a great question. I think I probably, firstly I think university partnerships with, I think that would be welcome on both sides and on all sides, and I can't think of a reason why whatever barriers there would be, we wouldn't have tremendous motivation to overcome them. Maybe, Sam, if that is you and you can put it on mute, that would be awesome. I don't know. I'll just keep on talking. But anyway, I'm not typing or ruffling papers, so I don't know how we can avoid that. Anyway, I think there's a lot of reasons why it will work. I think there's a tremendous amount of good that can be done from it, and I would actually advance that question by saying I think that universities that educate medical professionals, doctors, nurses, PAs, have an obligation to help improve the health in the communities in which they sit. I do actually think it's appalling that schools of public health and universities will sit in areas of extreme poverty and poor health. There should be a much better connection there, and if there were, everyone would benefit in so many, many ways. So I think it would be great if we could figure out what those barriers are and overcome them. I have a feeling that that question was aimed at a specific university and health center. We're fully, my university and the health center I work in are integrated, so I think it can be done, and maybe we just need to look at the models of how it can work better, or take best practice from those, and people can have like a menu of ways that it will work and can work. Maybe that person could provide a little more detail, and I could be a little more specific.
So, yeah, my sense of the question is, of course, it does stem from Barbara Brandt's article on aligning practice redesign. So this is about bringing universities and community health centers closer together. In this case, for the purpose of putting clinicians in training giving them opportunities to have firsthand experience, sort of like what the PCLP model does, right? So I guess the question is ultimately about how to expand the model. So there are a few, my sense is that there are a few institutions or a few communities in which that's happening now, but how do we proliferate that, reproduce it, more universities and healthcare delivery systems involved in that?
And is there experience that you guys have had at the PCLP that can help inform that as well? I wouldn't have a definite set, of answers for something like that, but I think, like you say, there are models out there, and the PCL program is one, the Summer Public Health Scholars Program from the CDC is another. So I think it can be, there are good models out there, and that scaling it is important. The only downside to it, I think, from a practitioner point of view, is the transient nature of students, which I think is, if I had to point to anything and there's nothing to really be done about that, but I just feel like we need to find a way that, long-term engagement is something that really helps people maintain their health. I think about it sometimes when I think about appointments that women in particular, and there may be men's appointments like this and I just don't know about them, but I know women who get their nails done every other week, but don't go to the doctor, right? So how do we there's something about those relationships, how they feel, how do I leverage kind of that nail salon experience, not to make it, I don't need a boutique doctor experience, but I think the transient nature of students paired with people who have, serious and chronic health conditions, we have to find the right balance so that the students can be helpful and learning, and at the same time, the patients don't feel like it's a rotation. And I would say that's the largest barrier to it in my mind. The patients, sometimes they want to be teachers, but sometimes they want to just be taken care of, especially if they're in a caregiver role in other areas of their lives.
Right, that's a really important insight, and really sort of thinking about the position of the patient. But I think, what you said earlier, that the Center for Health Innovation is a great model for that. And another place to look for the scholar who raised the question is the National Center for Interprofessional Education and Practice, I think is the name of it. But you could search on Barbara Brandt and follow what they're doing, because that's really sort of their focus, is to proliferate that model. So thank you, Dr. Cohen. Here's another question that came in just now from a scholar. This listening conversation is very biased towards the primary care provider. When the PCP listens and sends a referral to a specialty care, the patients then fall through the cracks, especially with the FQHC population. What are some strategies for primary care providers and specialty care communications, and how does the patient fit into that process?
Oh, I'm thinking for a minute. I don't know that I'm not sure I have enough information about what's happening with the specialty care, and I'm not sure that that's the experience all the time. In that sometimes in the specialty care, so where we are, things like dentistry and pediatrics are all co-located in the federally qualified health center. Is this specialty care as in a doctor outside of that service entirely?
I think they're probably referring to a specialist, yeah.
Yeah, I'm not sure. That's not been my experience, I'm afraid. And fall through the cracks. I mean,
so yeah, I'm wondering if the question is about a way of closing the loop of communication. So in saying that, that our focus here has been really on primary care, but, the system is broader than that. And, I guess maybe another way to put the question is, how do we get, if they're not already, how do we get specialists sort of in this loop of, a broader community population health focus? And I don't know enough about how these professions are set up. I don't know to what extent specialists are engaged or not engaged in these kinds of conversations. But do you have any insight on that?
So I think too that this may be state dependent in some ways. I know we when we do a referral to a specialist, you should receive communication from the specialist after they've seen the patient as to what their thoughts were and the process and what their recommendations, and we get a letter. I don't know that that's the case anywhere, and then it goes back to the primary care physician or the primary care provider to read the letter and incorporate or not incorporate as they see fit the suggestions of the specialist into the care of the patient. I think one thing that patients feel is that the system is very fragmented. They don't want to they don't want to be the person who has to incorporate what one person says and another person says. I think they're actually giving us more information. I too have seen what the last guy was referring to. What type of specialists are needed? Hold on, just 1 second, because I'm going to try to read this clarification.
Yes, it's a great question.
It seems that when these types of specialists are needed, patients do seem. So I may not actually be able to address this specifically, but it sounds like you send the person to a specialist, in this case an orthopedic surgeon, and then there's treatment and some type of intervention takes place, and eventually the patient winds their way back to you, or doesn't, but there are cracks in the system that the patient seems to fall through, and I actually don't. I wish I had a way to address that. I mean, one thing would be that if it's a passive system, in other words, and I think that this is, again, part of the retooling effort, but are we waiting for the patient to come back then to us to do the reporting back? Like, are we waiting for the patient to call us, say, I've been to the orthopedic surgeon and blah, 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 I would like to come in and update you, because I think that's probably not going to happen. We probably need a way to reach out to people so that it's not on them to do the coordination and the reporting back, that there should be a system either at the place where their patient-centered medical home is maintained, or another way that people are in communication so that that doesn't happen. I think patients feel it as fragmented care. Like they feel like the doctors aren't talking to each other. I feel like this question says the doctors aren't talking to each other, or the practitioners aren't talking to each other. But in the case that I'm accustomed to, a lot of times it is physicians. So I think patients are feeling this. It looks like you guys are feeling it. Practitioners are feeling it. So we need to put our heads together to think about how would we like to get communication from people. And what can we do? Maybe we can. That's another thing that that we can think about together. Is what would the ideal communication look like? Who should initiate it? Like, where should it come from? Who should initiate it? What should the follow-up be? And how do we know that it's taking place?
Right, and now the plot thickens because the scholar has added further clarification. So, for example, the person comes in to see a PCP. This part works well. Then it's realized that a specialist, like an orthopedic surgeon, is needed. It seems the orthopedic surgeon will be unwilling to see these types of patients, and thus the patients fall through the cracks. Wow. And so what scholars are saying is, we have observed this. That this
okay, no, that actually
happens.
Makes more sense.
Yeah.
I mean, that doesn't make more sense. That's appalling. But it's that understanding that that's what they mean, it makes the question make more sense. This is I mean, it would be wonderful if I could offer a solution in you know, the remaining time that we have together to this problem. But I think this is part of the, again, a retooling of medicine. That's, I'm sure it happens. I'm 100% sure it happens. I'm 100% appalled by it. To find it, especially, and I think that when they can find somebody, the wait times are unacceptable, and in some cases dangerous. So what do we do about that? I think that's a good question. Somebody had a related question that was sent in: was, is there a way to make people take a certain percentage of panels of their panel, you know, to take all comers in a certain percentage of their panel, something like this? And maybe policy is the way to address that.
Mm-hmm. Yeah, wow, I wish we could end on a more upbeat note because this is really, it's disturbing to realize that this is the reality. But I guess the upside is, you know, that all of you scholars and all of us here who are on the call are focused on this. We're paying attention to this, and you know, there is this opportunity to intervene, to advocate, to educate, and to bring about change in this system. Dr. Cohen, thank you so very much for sharing your time with us today. I know that you are en route to a conference in Canada, and you stopped off to spend a couple of hours with us today. We can't thank you enough for your time and for this great seminar. And as always, for being such a great friend to PCLP, who always seems to say yes to us. We really thank you. And a scholar has just written in to say, I really appreciate your perspective and knowledge. Thank you so very much.
Thank you guys so much for spending the time listening and thinking about this. My email address is here. I'm delighted to continue the conversation, and I thank you for having me.
Thank you. And so, scholars, we look forward to seeing you in Chicago in just a couple of weeks, where we will get to be face-to-face. We'll talk more about these and other issues. We have great speakers lined up for you, and we can hardly wait to see you in person. So thanks, everyone, for being with us today. We wish you the best for the weekend, for the holiday that's coming up, and be well. Take good care. Thanks again.